Welcome to the Deep Dive, the place where we take complex research and really give you the essential takeaways. Today, we're focusing our attention on a population that, well, demands some pretty specialized nutritional understanding. Infants, at significant nutritional risk.
Yeah, this is such a critical area, especially, given the success of modern neonatal care. We now have this growing number of survivors, particularly those extremely low birth weight infants who need highly specialized nutritional services for months, sometimes even years, just to catch up.
It's amazing progress, but it brings new challenges.
Exactly. And the sheer scale of risk here, it's kind of staggering. We're talking up to 40% of children and youth with special health care needs being at nutritional risk.
40%, wow.
And get this, for infants with developmental delays, that risk jumps to somewhere between 79% and 90%.
Wait, 79 to 90%.
Yeah,
That's nearly every infant in that category,
pretty much.
which just underscores why this individualized care is, well, it's non-negotiable, isn't it?
Abs-
So just to establish the context for everyone listening, we're focusing on infants categorized by low birth weight. That's low birth weight, or LBW,
Right.
which is less than 2,500 grams. Then there's very low birth weight, VLBW, less than 1,500 grams.
And then the most vulnerable group, extremely low birth weight, ELBW. That's less than 1,000 grams. Tiny.
Really tiny.
And these tiny individuals, they have immense variability in their medical conditions, their ability to handle food.
Yeah.
It just means we can't apply those standard nutrition guidelines. It doesn't work.
Okay, so let's unpack this. Our mission today is to really dive into the science behind their nutritional requirements, the specialized ways we track their growth, and the necessary interventions that tailor care specifically for these vulnerable infants.
Right. So to start, professionals look at three main categories that basically automatically trigger an in-depth nutritional assessment, the first group. That includes infants born before 34 weeks gestation.
Okay, so quite premature. These preemies are born, well, they're way behind the curve, aren't they?
They really are. They have inadequate nutrient stores because they missed that critical third trimester growth spurt in utero.
Right.
Their nutritional demands are sky high, and maybe most importantly, their gastrointestinal function is just incredibly immature.
So a triple whammy, really.
Yeah. The second group includes infants affected by abnormal development while still in the womb. This might be due to things like, say, cardiac malformations, or maybe exposure to teratogens like drugs or alcohol, or perhaps diagnosed genetic conditions like trisomy 21, which most people know as Down syndrome.
Okay, the third category.
The third category covers infants who are at risk for chronic health problems. This often stems either from their primary condition or maybe from the, rigorous medical treatments needed just to save their lives.
Right.
Think of conditions like cystic fibrosis, chronic seizures, or fetal alcohol syndrome.
Got it. So how do clinicians spot the risk early on? What are the
Uh-huh.
indicators?
Well, clinicians use key indicators to flag these risks. Things like reliance on tube feeding, maybe poor oral feeding skills, altered growth patterns, or energy needs that are just highly atypical, way off the standard charts.
Okay.
And, when professionals have to deliver this kind of news, it's so important they remember the huge emotional context. Parents might be coping with the trauma of a difficult birth, maybe grieving the loss of the healthy, perfect child they dreamed of. And that absolutely compromises their ability to process and really comprehend the complexity of the baby's medical and nutritional plan.
That sensitivity is just crucial, isn't it? Because we're asking these parents, who are often dealing with trauma and grief themselves, to immediately grasp this level of nutritional complexity. It's completely unlike standard infant care.
Totally different ballgame.
So once we identify who's at risk, the next step is nailing down exactly what they need nutritionally. And this is where you said the standard rules kind of break down entirely.
Correct. The standard recommended daily allowance, the RDA. It's simply inappropriate for these infants. Instead, specialized care relies on something called the Estimated Energy Requirements, or EER. This involves, pretty complex predictive equations that account for growth goals, physical activity, total energy expenditure. It's all about making sure the plan is truly individualized.
And depending on the medical reality, those energy requirements can swing wildly, right? So who typically needs more fuel?
Right. So infants who need significantly more energy, we're often talking 110 to 135 kilocalories per kilogram.
Well, that's a lot.
It is. This includes premature infants, those recovering from surgery, or those with conditions that make breathing difficult, like bronchopulmonary dysplasia or BPD.
BPD, remind us what that is.
Sure, BPD is a chronic lung condition. But basically, the baby has to use a significant amount of energy just to breathe. It really drives up their caloric demand just for baseline survival.
Okay, so their little bodies are working incredibly hard.
Exactly. But conversely, some infants actually need less energy. This might be due to reduced activity levels, which is common in conditions like Down syndrome or spina bifida.
And the risk there is.
Well, if we overfuel these infants, we risk contributing to overweight early on, and that can set them up for negative health outcomes down the line.
Right, finding that balance is key.
And this is where we really need to look at the structural foundation.
Mm.
Protein. Protein requirements are already high in infancy. The standard DRI is about 1.52 grams per kilogram up to 6 months.
Okay.
But for extremely preterm infants, especially those born before 30 weeks gestation, that intake might be required to be as high as 4.5 grams per kilogram.
Wait, 4.5 grams per kilo. That sounds huge. That's nearly triple the average requirement. Why wouldn't that massive intake overload the baby's immature kidneys?
That's an excellent point, and honestly, it's a constant clinical balancing act. But the reason for such an aggressive protein target is profound. Protein isn't just for muscle, it's vital for the actual structural scaffolding of the brain and for supporting linear growth. The focus isn't just on making a baby heavier, but making them longer. That linear growth, it's a direct proxy for cell replication and brain structural development. That's why the sources emphasize it links directly to later cognitive outcomes.
I see. So the immediate biological imperative is building the brain's infrastructure. And the risk of, say, temporary kidney stress is accepted over the risk of permanent neurodevelopmental impairment.
That's essentially the calculation, yes. And if the infant's digestion is impaired, which is very common, they might need specialized forms of protein, things like partially or extensively hydrolyzed formulas, or even formulas based entirely on free amino acids.
Okay, breaking it down for easier absorption.
Precisely. And we can't ignore fats and micronutrients either. Fats should provide a huge portion of daily energy, somewhere between 45 and 55%.
Why so high?
Well, because of their caloric density, firstly, but also the need for essential fatty acids for neural development. Preterm infants often need something called medium-chain triglycerides, or MCTs, specifically because they don't require bile for absorption, which helps compensate for reduced liver and pancreatic enzyme function.
Interesting. Okay, what about key micronutrients?
Well, regarding micronutrients, a really crucial intervention for preemies fed their mother's own human milk is iron supplementation, specifically at least 2 milligrams per kilogram per day.
Okay.
And this brings us to human milk fortifiers, which are routinely used in the NICU.
Right, the fortifiers. What's their role?
They're essential because while mother's own milk is absolutely optimal for immunity and gut health, it just doesn't naturally provide enough energy, protein, calcium, phosphorus, or other minerals.
Not enough for these specific high needs.
Exactly. Not enough to support the extremely high growth rates required for that critical catch-up growth. So the milk literally has to be boosted.
Makes sense. So once the requirements are set, we move to tracking growth. And you mentioned earlier, this is a major point of departure from standard pediatric practice. We can't just use standard growth charts.
That's right. Standard charts. They're just misleading for this population. We absolutely must use specialty charts like the Fenton or Olsen curves. And we need to integrate additional anthropometric measurements, things like mid-arm circumference or triceps skin fold, to assess body composition, not just weight gain.
Okay, looking beyond just the number on the scale. But you said the single most critical concept in tracking growth for preemies is using corrected age. Can you explain that for us? How does that work?
Sure. Think of it like running a race. A baby born 3 months early basically starts 3 months behind the official starting line. Corrected age means we're measuring their progress only from the point where they should have started the race, you know?
Okay, adjusting for the prematurity.
Exactly. We take the chronological age, how old they actually are since birth, and subtract the number of weeks or months they were born prematurely. So a 12-month-old baby who was born 3 months early gets plotted on the growth chart as a 9-month-old.
Ah, I get it. That ensures we're comparing their growth trajectory fairly, comparing apples to apples, sort of.
Precisely. And the research here is really clear. higher growth velocity, specifically aiming for around 15 to 20 grams per kilogram per day, during that initial hospitalization period is linked to better neurodevelopmental outcomes later on at 18 to 22 months corrected age.
So that rapid catch-up growth is literally building a better brain foundation.
That's the goal. And if we connect this to the bigger picture, this really is the core of the fetal programming hypothesis. Early conditions, like being born preterm or having intrauterine growth restriction, can influence lifelong health. The tightrope walk for clinicians is needing that aggressive, high-growth velocity for the immediate neurodevelopmental benefit. Yet knowing that rapid excessive weight gain later in the first year can actually increase the risk of chronic adult diseases like hypertension, heart disease, diabetes.
Wow, that's a heavy responsibility. Balancing immediate needs against long-term risks. Okay, let's look at feeding methods then. The challenge seems immense. You mentioned 42% of prematurely born children experience problematic feeding.
Yeah, almost half. The barriers are both physiological and environmental. Physiologically, that coordinated suck-swallow-breathe pattern, it just doesn't fully develop until about 32 to 34 weeks gestation.
So they physically can't do it effectively before then.
Right. And then environmentally, think about the NICU. The negative oral tactile experiences, frequent suctioning, the placement of feeding tubes can lead to what we call disorganized feeding.
Disorganized feeding.
Yeah, the baby basically learns to associate anything near their mouth with stress and aversion, rather than pleasure or feeling full. This creates immense stress for parents who are trying to transition the baby to feeding by mouth.
Oh, that sounds incredibly difficult. So what's the typical progression of feeding methods?
Well, the sequence usually starts with parenteral nutrition. That's IV support, providing nutrients directly into the bloodstream.
Okay, bypassing the gut initially.
Correct. Then, as soon as possible, it moves to enteral feeding via gavage. That means using orogastric tubes mouth to stomach or nasogastric tubes nose to stomach until that oral coordination develops.
And if they need longer-term support?
For infants needing support for over 3 months, they might transition to a more permanent solution, like a gastrostomy feeding tube or G-tube, which goes directly into the stomach through the abdominal wall.
Okay, and what about the choice of milk for enteral feeding?
Yeah, this is critical. Mother's own milk is always the optimal enteral choice. If it's unavailable, pasteurized donor human milk is the next best recommendation.
And the alternative is preterm formula.
Yes, but there is a serious, potentially life and death trade-off when using preterm infant formula. While these formulas are calorically dense and have added nutrients, their use is associated with significantly higher rates of necrotizing enterocolitis, or NE.
NEC, that sounds serious. What is it?
It's devastating. NEC is a severe intestinal inflammation that can actually destroy the intestinal wall. It requires urgent medical and often surgical intervention. It really highlights why the protective immunological and gut maturing factors in breast milk are literally gut-saving for these tiniest, most vulnerable infants.
Wow. That puts the breast as best recommendation into stark perspective for this group.
Absolutely. On a more positive note, though, a small intervention that can make a big difference is non-nutritive sucking.
Meaning?
Just letting the infant suck on a pacifier or even suckle at an empty breast between tube feedings. Research shows this practice actually helps reduce hospital stays and facilitates that necessary transition to actual oral feeding later on.
Interesting. Such a simple thing with a potentially big impact.
Mm-hmm.
We should also briefly touch on infants born with congenital anomalies and genetic disorders, things like cleft lip and palate.
Yes, those conditions make feeding difficult right from the start because the infant often can't establish an effective seal or generate enough suction to feed properly.
Yeah.
And it's worth mentioning, the major public health success story achieved with neural tube defects like spina bifida, their prevalence was reduced by about 28% thanks to the mandatory folic acid fortification in enriched grain products that started back in 1998.
That's a huge win.
Yeah.
But for many other infants with genetic conditions, the real stakes lie in those expanded newborn screening programs, right?
Absolutely vital.
Yeah.
These screening programs catch genetic metabolic disorders like phenylketonuria or PKU and galactosemia right after birth. And the sources really stress this. Failure to implement immediate medical and nutritional treatment for these conditions can result in severe intellectual disabilities, metabolic crises, growth failure, or even death.
The stakes couldn't be higher.
They really couldn't. These diagnoses require incredibly timely nutritional support, often using specific prescription-only formulas known as medical foods. These are specially designed to manage chronic metabolic disorders by severely restricting certain compounds that the baby's body just cannot process safely.
Okay, so highly specialized formulas for very specific conditions. Now, once all these complex challenges are identified, what specific interventions are typically implemented to try and stabilize growth and get these babies on track?
Right, the intervention is highly detailed and proactive. First, frequent monitoring of all growth parameters is key: weight, length, and critically head circumference, because that reflects brain growth.
Okay, constant tracking.
Second, clinicians will often change the caloric density of the feeds. They might target higher calorie concentrations, like 22 to 30 kilocalories per ounce, compared to the standard 20.
Concentrating the formula or milk.
Exactly. Third, they'll adjust the feeding frequency or the volume given at each feeding to meet those calculated nutrition goals. And fourth, they carefully modify the timing of meals around things like medication schedules or sleep schedules, just to optimize intake and tolerance.
It sounds like a very dynamic, constantly adjusted process.
It really is.
Finally, for parents listening, accessing support is crucial. What kind of programs are available for families with high-risk infants?
Yeah, that's important. High-risk infants may qualify for several programs. There are early intervention programs under IDEA, Part C. There's Early Head Start. WIC, the Special Supplemental Nutrition Program for women, infants, and children, can also be a resource. And most states have specific children with special healthcare needs programs.
Where is the best place to start looking for this kind of specialized help?
Typically, the best point of access is through pediatric specialty clinics, whether that's a cardiology clinic, neurology, a GI clinic, or specific metabolic clinics. These clinics frequently include registered dietitian nutritionists, RDNs, right on their teams, specifically to manage these highly individualized and complex nutrition plans.
Okay, so working closely with those specialty clinics is key. Wow, that was a tremendous deep dive. We've covered the unique physiologic demands, the critical nutrient targets, the specialized tracking, and the interventions required for this incredibly vulnerable infant population. As we wrap up, what really stands out to you as the major synthesis of our discussion today? What are the absolute key takeaways?
Good question. I think what really stands out is the extreme level of individualization required. There's just no one-size-fits-all approach here. Also, the critical difference between chronological age and corrected age, understanding that is fundamental. And finally, the essential, truly non-negotiable role of specialized nutrients, like those aggressive protein targets we discussed, and the use of human milk fortifiers in achieving that absolutely vital linear catch-up growth, which is so linked to brain development.
Excellent summary. And perhaps here's a final provocative thought for you, the listener, to reflect on. The research on fetal programming strongly suggests that optimal nutrition in this first year doesn't just impact immediate survival and growth. It potentially influences lifelong health measures, like the risk for adult chronic diseases, maybe even later school performance. So this raises an important question. Considering the potential future costs, both human and financial, of chronic disease, how much of an investment are we truly making now in specialized nutritional care during this critical window to potentially prevent those future lifelong health costs?
That's a vital question indeed, something we definitely need to keep thinking about.
Absolutely. Thank you so much for diving deep with us today. We'll catch you next time on The Deep Dive.